do you have a sense when you have a patient with renal cell carcinoma, and again, we use our IMDC criteria, but do you have a sense when you see somebody that, gee, I got to pick my best regimen up front because they may not make it to second line? And what drives that sense of, of immediacy for treatment?
Yeah, always. I mean, I think that, you and I and Niraj and Reina, we've all contributed to several of these data sets, both in the context of IMDC and outside of that context, that really reflect the very high attrition from first line to second line that we saw in the TKI era. I mean, for instance, some studies like the IMDC data sets reflect just 50% of patients making it to second line treatment. Those numbers may be a bit better in the context of VEGF-IO. We just don't know yet at this point, I think, by and large. But, I would suggest that data, which implies that a substantial proportion are not going to get the second line, means you can't save the best for last year. You've got to put your best foot forward right up front.
Yeah, I agree with that. And you mentioned bone mets. I mean, to me, symptomatic bone mets, that's one of the things that I really worry about in this disease, that, these patients, can run into trouble, very early on. I think another is just tumor burden. These patients that have really symptomatic high tumor burden, when they have progression, they're already carrying kind of a critical mass of tumor burden. And to me, the third is the type of symptoms that patients have. I mentioned pain. The other to me is weight loss. When I have a patient, and we see this with kidney cancer, a patient has a lot of weight loss. That weight loss, we'd like to think that's like liposuction and body fat, but it's mostly muscle, and when you lose muscle, it just makes, everything that much tougher to tolerate and be able to get to, your second or third line of therapy. So I think there's a few key factors to me when I'm looking at these patients, some way a little bit more than others, that really make me think, gosh, I got to take that first best shot. And if they don't tolerate something, I can dial it back. But we may not get a chance to do some fantastic salvage regimen if they don't get some disease reduction in this first line setting. Okay, great. Well, I want to be conscious of time, but I want to bring up one more thing that Reina brought up, and then I want to ask about side effects, because I think these are the other key thing. But Reina brought up biomarkers. And I think biomarkers are really key. And I know all of us have done studies, invested a lot of time and energy in understanding biomarkers. And one biomarker that's sort of out there, it's prevalent. It may show up on every tumor profile. You may get it in your path reports regularly. It's the PD-L1 status. And I'm just curious, when you see a tumor that's PD-L1 positive, or you see a tumor that's PD-L1 negative, how does that factor in your decision, or does it factor in your decision at all, and how you're going to manage that patient? It's not part of our IMDC. Niraj, do you use that information?
I get that information, but I don't use the information. That's how I would put that.
Okay.
Yeah, I mean, like most of the sequencing platforms, they report these information.
Yes. So you're interested, but not enough to act. It's not going to weigh in your decision on how you...
I think more than whether I'm going to use a PD-L1 axis inhibitor is whether I'm going to use a combination regimen versus a VEGF TKI based regimen. Right. So that's a bigger decision making in my clinic.
Others, same feel? Reina, you're smiling? You use it a little?
Well, first off, I mean, we know that PD-L1 status and RCC is prognostic. People who are PD-L1 positive seem to do worse compared to people who are not. But when we look at, for example, the 3 frontline trials with approved therapies in the frontline space, each of those trials used a different assay to determine PD-L1 positivity versus not. And there really isn't, maybe the responses are going to be higher in PD-L1 positive patients, but PD-L1 negative patients can respond. It's not a pure biomarker. You're not going to restrict therapy around PD-L1 status. So I think right now it really hasn't been integrated into clinical practice. Like, yes, we get it, we look at it, and we haven't even validated the right assay yet. So I think there's still a lot that needs to be done. And each of these studies, like there was some elegant work that came out from Javelin Renal 101, and you know, Checkmate 214 kind of evolving, but each of these trials did their own set of biomarker studies and not a lot of integration across all three trials, and sort of urged the field for us to try to, you know, like synthesize that and integrate the same biomarker panels across these trials so we can learn something and try to better select our patients and beyond just like IMDC criteria. You know, I don't think we're there yet. I still think we have a lot of ways to go.
And it seems like something that maybe could be induced, right? We're using these archival tissues to describe this, in that then you're treating these patients with say a VEGF TKI and an IO. How much of that PD-L1 status is changing in vivo in these patients, and we just don't even know it. So, there's a lot of limitations that archival tissue. But something that probably doesn't change is something like a sarcomatoid element, and that's an aggressive element to tumor, and it's probably a little bit more of an inflammatory element. Certainly, you know, very different histology associated with the disease, and you know, we don't see it that often, but maybe 10-15% of the time we'll see some significant component of sarcomatoid element. Monty, does that factor? Do you note taken, but doesn't change what you do, or do you use it in some way?
Yeah, you know, I think one of the most impressive outputs of all the immunotherapy studies has been the sort of consistent benefit that we see with the application of immunotherapy with sarcomatoid features. So if I see a patient with, you know, a substantial proportion of sarcomatoid elements, I'm definitely steering them towards nivo at the upfront.
Yeah, and it's interesting because you see it not only with, you know, with the response, but even with a complete response, which, you know, to Niraj's point, you know, is really remarkable, because, you know, the sarcomatoid elements are rarely 100%, right? Usually you get like, you know, it's 10%, it's 30%, it's some proportion of the tumor, and yet there you're having, you know, these really, you know, much more dramatic effects, and it really suggests there's some sort of almost like bystander effect. Once you've got that immune activation associated, it starts killing all the tumor, and you can get these, you know, pretty remarkable complete responses. And we're not talking necessarily taking, you know, a couple of small lymph nodes and shrinking them away. Sometimes these are patients with liver, bone, bulky metastases responding. So I agree with you. I mean, these are the cases where, you know, I think, you know, even if it seems a little bit of a stretch, I'll consider that, because it has such a dramatic result associated with it.